Good afternoon, everybody, and welcome to the London offices of Mills and Reeve. The sun is shining. We have gorgeous views of the Shard, of the Monument, and of Tower Bridge, but you can't see that. But what you can see here today is Nigel Edwards and Roy Lilly, who we're absolutely delighted to welcome to our offices. And I think you'll be in for an absolutely fascinating conversation this afternoon. So I'll hand over to both Roy and Nigel.
Jill, thank you very much indeed. Well, welcome everybody. If you're watching us at home, it's really nice to be here actually live. I think this is the first health chat we've been able to do live since, is it 3 years? Yeah, Shane's just told me it's 3 years. It seems so much longer. And I'm really here. Unlike ABBA, I'm not an avatar, although in the script it did say I'm not an abattoir. So we really got that right. Listen, we can only make these things work because of the generosity of our sponsors. And so why don't we just take a moment for me to introduce Liz Asher-Payne from Orca, who will tell us exactly what Orca does, because nobody really understands it. If you could just leave me 5 minutes at the end to talk to Nigel, that would be really good.
I will try. So yes, it's a real privilege to be able to support this session today. My name's Liz Asher-Payne. I'm the Chief Exec at Orca. We're all about supporting the infrastructure to assess, evaluate, distribute, and then get great quality digital help to people who need it to improve their lives. I've known Nigel for a long time throughout my career, and so I'm really looking forward to hearing what Nigel's got to say. And over to Shane.
This is the last presentation of a sponsor book. I'm Shane Tickell from Aurora Health Technologies, and we're really well known for collecting data at scale for real-time care, population health and research. And we're doing it for about 7.5 million people across London right now, and we can do it for nations. What I'm really thrilled about is to continue my relationship with the Institute of Health and the Health Chats. And Nigel, it's a great pleasure to be with you this morning, and Roy, and we look forward to the session. Thanks you
very much. Good. And my guest, Nigel Edwards. Big round of applause. Yeah. Nigel came here. I thought Nigel would have arrived in a chauffeur-driven limousine, as did I, but you arrived on a bike. Yes. Tell us about your journey, Nigel.
I've discovered that cycling around central London is the way to go. So I haven't used a taxi for years. I'm a bit of a fair weather cyclist. And the other thing to remember is you mustn't call it Boris' bike. It wasn't his idea, and we're trying to get it.
But isn't it funny how the branding of Boris and the bikes is stuck?
It's alliteration.
Yeah.
There's not enough alliteration in health policy. That's one of the reasons why.
But it doesn't work.
It's wrong.
Yeah. Although when Boris was around in London, I mean, I have to say this. I mean, you have to kind of be careful how you say this, but there is a bit of Boris that I was a big fan of. And that was when Ruth was, she was, bless you, let's try and use the Bolivian stuff, it's not as dusty. When Ruth Carnell was the regional director of London, she had quite a lot to do. Later on, she had quite a lot to do with Boris. And he wanted actually to take over the management of healthcare in London. And I thought, given the efforts that we've had to try and move local government closer to health services, and clearly, the road to good health starts a long way from the front door of the NHS. I think that was a bad idea.
Well, remember, London has got the population of Bulgaria, so it's the size of a medium-sized EU country, so not that local. The other dynamic in London that's quite tricky is that the boroughs don't necessarily get on terribly well, and definitely don't get on that well with the GLA and the so I'm not sure how that would have worked out. I think it's an interesting idea, whether he'd be the right person to do it. One of the problems with the NHS, as I see it, is how centralised it is, how far it is from the actual action. The UK is very centralised. I think Simon Jenkins is as centralised as North Korea. Sounds plausible. So taking it closer would have been an interesting.
Well, what about the opportunity, for example, in Manchester? Andy Burnham, former health minister, mayor of Manchester.
Well, I think just by comparison with, say, Spain and the Norway, Sweden, and some extent Finland, they're reorganising. There's quite a lot to say to getting it closer. Quite a lot of our local government isn't quite big enough to have this critical mass. I think Manchester's a good size. London's perhaps a little of a big size. My observation around Europe is that sort of 1 to 5 million works pretty well. push it to 7 and a bit for Catalonia and Andalusia. They worked quite well. But
About 3 million, 3 million, was it Denmark 3 million?
Denmark has got 5 regions of about 1 million each. So basically, can you get the people you need to in a reasonable sized room, rather than one ICS I went to visit that had to hire a very large church hall, and even then it was a tight squeeze.
Yeah. Well, we'll come on to ICBs in a minute, but I mean, we're really here discussing the healthcare because you're retiring from your role as chief executive of Nuffield, and I must say, on a personal level, I've admired enormously the work that you've done, and I think it's a great shame you're going because you're still a relatively young man. Well, how did it all start for you? Were you in KPMG?
No, I started on the National Management.
Oh, before that, yes, yeah. We've got someone in the audience who's on the National Management.
They
Still going.
They get around. I did operational management at Central Middlesex, which is a very unusual hospital in that it seems to attract interesting people. I might claim to be one of those. Mark Bricknell, Richard Dobb, Doctor Smoking, Ara Darzi, Sally Davis was a young hematology consultant when I first started working there. Was about as frightening then.
She is now. Sorry, Sally.
She was great. She's had.
We're being asked to speak up a bit.
Okay. So I did a good stint in operational management there. I then did some work on implementing the 1990 reforms at Oxford region, and then I got interested increasingly in health policy and health strategy. I went to the London School of Hygiene and Tropical Medicine, where I did contract research and consulting, and we did both international. I then got my first taste of international work. Think about hospital strategy in Hungary, reforming the healthcare system in Kyrgyzstan.
Well, no one knows where Kyrgyzstan is.
It's south of Kazakhstan and to the west of China. And Uzbekistan is on the.
And some of their healthcare systems are horrible.
The former Soviet systems, some of them are still pretty unformed. Actually, I was working in Ukraine before the invasion. Quite a bit of the ways of working and ways of thinking are unchanged.
After Czechoslovakia, I went there after they had their revolution there, and looked at some of their mental health services, and they were just horrendous.
So Nikolai Shimashko, who was Stalin's first commissar of health, thought that everything should be standardised. He was fitted right into the new hospitals programme.
The 30 years.
Very, very well. However, whatever the number is, and that spread pretty much across the whole of the USSR. The Baltics and Czech Republic and others didn't quite adopt it to the same extent, but there's quite a long legacy still of those primary care, clunky infrastructure that doesn't really work, and some quite old-fashioned approaches to the patient. It's changing fast. It's an interesting place to work. So I did that for a number of years, and then I went to the NHS Confed, where I helped set up a policy function.
Yeah, I remember that. Yeah. John Greetham and I set up the conflict with £5 grand that goes from the Department of Health.
Yeah, we had that in a box.
Yeah.
When I joined it, it was quite small. We managed to grow it and make it quite successful. But I then went to the King's Fund and worked for KPMG and the King's Fund.
Yeah, I remember. I knew. Just wind the clock back to when you were first a manager, and compare really the experiences of being a manager at that time and being a manager now. Do you think it was easier then, or what?
Well, it's probably easier because there was a sort of tacit understanding that, on the whole, managers did not interfere in the way the clinical work was done and organised.
No, it's worth reminding ourselves. Of course, the idea of general management came in after the Griffiths reforms. And Griffiths, for people who are not sure who he is, he was a kind of Richard Branson figure of his day. He was a director of Sainsbury's who just started doing supermarkets, and they were all new because there was life before supermarkets. And Roy Griffiths was a big favourite of Margaret Thatcher. And Thatcher came in and she was completely mystified by the NHS and couldn't understand where the money disappeared to. So she got Roy Griffiths in to do the Griffiths report, which I'm sure you remember. And it was as a result of that we went from a health service that was really dominated by consultants, I think, to having some form of local management.
So the model it replaced was what was called a consensus model, in which was a chief nurse, a chief doctor, and a chief administrator, and they reported up parallel lines to district health authorities, whether it's the same.
That's where I was.
Three-part structure. So Roy Griffiths said, "Who's in charge?"
Yeah.
And he couldn't find out who actually was in
He
charge.
famously wrote in his report, didn't he, that if Florence Nightingale, but you told me
So the quote said, "Florence Nightingale was walking the corridors of hospital with her lamp, should be looking for who's in charge."
Yeah.
So his proposal was to create general management. There was a great fad then for bringing in retired admirals and generals and people from industry. And where I worked, we brought in someone who ran a business with 60 employees who suddenly found himself running something with 5,000 employees. So it had mixed trouble. I think if you look at it in an international context, actually, there's a long-standing trend over time, often driven by ministers of finance, to set really by there's all this money going, to try and get better accountability and to improve efficiency. So you see this sort of incursion of management into healthcare across many countries. I think we're a bit unusual to the extent that there's perhaps less clinical involvement in elements of management here. The frontline doctors have perhaps have been in the past less signed up to that. That seems to have changed. But
there is a tension. I think it's fair to say that if you were just going to generally characterise it, difficult, because I mean some hospitals are entirely different and they run entirely different, but there is a general tension, I think, between management and frontline clinicians.
Yeah, I was very friendly with a political scientist called Peter Degling, who had done studies in a number of countries around the world, where he asked doctors, nurses, and managers about their attitudes to various important dimensions of organisational function. And what he discovered across all continents, that doctors, managers, and nurses have very different views about, for example, autonomy and accountability, which are a bit opposed to each other, so they're on a continuum, or about the extent to which clinical work should be subject to systematic processes and control, other than, or something a bit more free flowing. Different views about how the role of financial decision making. So managers would say clinical decision is a financial decision. Doctors were saying, well, we have nothing to do with that. So you then plot them on these graphs, and then you'll be able to see that the doctors, managers, and nurses were in quite different locations on a number of very key issues, some of which relate to quite some fundamental values, like how you think about your work and what you do. The good news is, before he retired, he had noticed that there was a degree of coming together, that the different tribes were starting to converge. But there is a sort of still, I think, a quite legitimate and probably unavoidable difference in worldview.
I think good managers create the time and space for good people to do great things. I've always thought that, and that's the role, I think, of managers. If you were going to talk to young people thinking about a career in management now, would you recommend the NHS?
Well, I think there's some aspects of the NHS which are fantastic, and as a management job, there are a few that are as challenging as complex. So it's a great way of cutting the teeth and learning how to do it. I think that I worry about several aspects of NHS management. I think one of the problems that particularly bothers me is the extent to which Gordon Messenger's comments in the Times a few days ago. I think there's quite a lot of what he says there, that there is a bit of a feeling that there's too much looking up still, despite years of rhetoric. I mean, you're like me, boy, I've heard many people say, "Oh, we must stop looking up, and we must
look out,
or look
down,
up."
round.
But there is still a strong feeling, if we're not careful, that the customer of the NHS is the Secretary of State, and the role of quite a lot of the management systems is to make him feel less anxious.
Yeah,
less anxious. That's less on.
I was quite critical of the Messenger report. I didn't think really it had a great deal of relevance. I think it was written by a soldier who did everything from the centre, and when he said jump, everybody said how high. And the NHS is a kind of loose federation of independent organisations who say jump, and they say, well, when we get around to it, we might.
I'll have to go back and refresh my own, but I seem to remember that the concept of mission command, which is actually, these are the broad objectives, this is what we're trying to achieve, but the how you do it and the negotiation of that at the local level was part of his criticism was actually too much top down. And I think if I remember rightly, he was saying actually, everyone characterises the army as military being very top down, but actually it's only top down on a few really important things. And what we're really doing is relying on the field commanders to actually interpret and do it. So actually, it's quite consistent. I mean, I think part of the problem is that actually we've still got too much of an upward culture. He also talked quite interestingly about blame, and actually there's a long literature on sort of blame and finger pointing and blame shifting behaviours in healthcare more generally, but it does seem he picks up. So I think these are things to be thinking about. They are a challenge, and I think we do need some quite significant changes in every reform I can think of. People said we need to have a change in the culture of the NHS. A bit vague on from what to what, but generally more devolution, more accountability and delivery, a better theory of change, more use of tools, techniques for improvement and redesign of care, rather than muddling through and making it up. So basically, more professionalism in the design of care, better use of the evidence, and better evaluation of the results and willingness to change when you learn that you're not working. But all of those really important. The problem, I think, there's so much firefighting and sort of damage to the operational things. But one of the jokes that we used to make about talking to people in many organisations, particularly acute trust, is that next week is strategy and the week after is the unimaginable future. Part of that is that people are sort of pressed by the now and don't have time and space to think about how things should be.
What do you think about talent? Do we have enough talent? Do we develop talent? Do we just kind of snuff talent out?
Do meet some really fantastic people in both management.
Absolutely.
So I don't think the problem is the ability to attract talent. I think the problem is more giving people the time, space, and tools to make most of it. One of the things that strikes me, particularly when I go to somewhere like, I went to Kyrgyzstan. I went to get back to again. This time I was working actually there rather than working remotely, which is what we did in the 80s. And I was really struck by the fantastic team of health strategy people they had in the ministry, about 5 or 6 really brilliant women. One rather poor put upon that who was doing the health financing. They're all great, but underneath them was nothing. So I think this is a bit of a problem here. We've got the talent, where it's A, directed to the right things. Is it actually spending its time doing the right thing? And B, when it does, is a delivery machinery underneath it to take to eventually.
There's a kind of common trope, isn't there? Men in grey suits, pen pushers, spending a fortune on salaries. It's a typical Daily Mail headline. But if you actually look at the numbers and compare the percentage that we spend on managers and the number of managers we've got with OECD comparators, EU comparators, we're very light on management.
Yeah, I don't know. That's what the figures suggest. So we normally get a figure about 3.
It's 2%.
Yeah. Well, yeah.
And Simon Simmons should say £1 in every 100. I think it was actually a little bit more than that. But
I don't know how we're counting clinical managers in that figure, for example.
Well, it's worth pointing out that 1 in 3 managers is a clinical manager.
Yes.
That means they're a clinician and they're a manager. Or does it mean they were a clinician and are now a manager?
Or they're doing 1 PA a week.
Yeah.
I don't know how that's captured.
No, I don't.
But I don't feel. I mean, when I visit organisations, there is a lot more management than when I worked in hospital.
Yeah.
So, aged 6, I think I was responsible for a third of the hospital staff. Yeah, which is mad. I mean, so I had functional managers like a catering manager, a estates manager, and all those people
who really know their job.
Thank God, knew their job. Yeah. So my job is to basically help them do their job better, not just tell them what to do.
Don't mess with the estates department.
Definitely don't mess with the estates department. They will. Yeah, they will come and sort you out. But there are a lot more people. But then the loss. I think one of the things that people forget when you get the old feedback matron and all that, is the velocity at which our systems now work. So a matron, I think matrons predate me. But when matron was stalking the wards, the average length of stay for hernia repair was probably about 7 or 8 days.
And the patients used to get up when they were well enough to get up and serve the teas and coffees.
Yeah. So, you know, and now it's in hours. So the velocity, the speed with which the idea that vast numbers of patients now go home at zero, emergency admissions go home at 0 and 1, the amount of day surgery that's done, so the speed with which systems work. So they work more, and they're more complex, you know, because there's the pathways through hospitals involve more diagnostics and more procedures, so there's a lot more to manage. So I think the complexity of it has grown exponentially. In fact, I do wonder, one of the challenges that we've got is that we've got in a lot of places the cost of complexity and coordination is starting to be really quite significant.
Yeah. What about, let's just talk for a moment about technology. My take on technology is that it's largely failed. We've spent billions on it. We still can't talk to each other. Junior doctors still can't get your records. Nothing is interoperable. It's been a complete bloody mess, and I don't really see the way forward. I mean, is your legacy, can you enthuse me on the future of technology?
Well, there are certainly pockets where it works really well. I mean, you certainly look at it.
But that's the story of the NHS.
Oh, yeah, of course. Yeah.
You just can't get it all working in the same place at the same time.
No, I mean, the digital technology and actually diagnostics as well. It is kind of one of the sort of diagnostic signs of what's wrong with how the NHS is managed nationally, which is we prioritise short-term over long-term. See this in having £10 billion of backlog maintenance and not rebuilding hospitals for 10 years. We've basically not built any new hospitals. I finished 2 or 3. COVID didn't have collapse, but we stopped building hospitals. We haven't been buying CT scanners and radiotherapy equipment the way we need to. We've not been investing in diagnostics, and we haven't been training workforce. All part of a very short-term, penny wise, pound foolish approach to how we spend our money.
That was mainly the 10 years following the World Banking crisis and the fallow years.
I think it's a feature, not a bug.
Thanks.
Yeah, I think it's a feature, not a bug. I think it explains a number of other things potentially too, which is sort of slow uptake of innovation. Is that we don't think long term, we don't invest, and so actually a lot of the technology is people buying bits. We haven't invested in people with the capability. We pay the people who are responsible for developing and putting the systems in. We're not competitive with other sectors of the economy. I do also wonder whether there's just sheer scale. I used to have this debate with people like Ian Dodger, and it's saying that say, well, the advantage of the NHS is you can just think of something that's good and then roll it out everywhere. Well, no. It depends what it is. If it's anything complex, the answer is no.
Yeah.
Because it's got to fit into the local system and context.
Well, I mean, there's a very good social structure. There's a very good example of that right now, and it's very topical, and that's virtual wards. Now, all the work that the IHSCM has done on virtual wards is not cheap. It's got to be done by people who really know what they're doing, and it's not an easy answer. But it's a fact. And now everybody's got, we're doing virtual wards, and I'm kind of worried for Granny about that.
Well, yes, I suppose there's fewer risks in virtual wards than there is in buying information technology. But it is part of a similar sort of mindset, which I think is that I'm feeling the virtual wards is probably not so guilty of this, but an understanding that the local context of implementation matters. There's been no real sort of grip on information policy, but I was just about to say I think that there is something about the sheer scale of the NHS that means that it's then so complex that we saw how what's his name, Richard Granger,
connecting
to health. I think just ran into the sheer size and complexity of the task and it sort of defeated them.
Well, I mean, Richard did quite well, I think. I mean, without Richard, we wouldn't have email, we wouldn't have electronic prescribing. So
we don't have electronic health records, which is where the big win is.
But that was never his job. When Connecting Confed was set up, it was only later that somebody turned up and said, oh, by the way, we want to be able to book appointments online like the airlines, and we want to do the electronic health record to be seen everywhere. And that was never funded for, and it never planned for. So they tried to do it post the event, really. And we still kind of, do you think, I mean, the fact that it is so big, do you think that the way to handle this is going back to Messenger is maybe we should say, okay, on Monday, we're going to buy all these boxes of kit. It's all going to be the same. We're going to deliver it on Tuesday, plug it in on Wednesday, show you how to work it on Thursday. And by next week, you're going to be using it. As it is, we've let Trust buy pretty much what they want, whether it's any good or not.
Yeah, I think you can let Trusts, you ought to be able to let Trusts buy their own systems. But you've been very weak on saying what are the interoperability parameters, how does it connect, what's the data architecture that you've got to use. So I'm torn on this. The problem with very big national procurements is the time they take, and the capability of the system, to actually do that well. The other problem, back to the short-termism, is, and really back to the Richard Granger example, is that the organisation development, training, and implementation costs are never really properly accounted for. Because you'll buy the boxes and wires and go, there you are, those boxes, good luck. But actually,
Cambridge was an example, wasn't it? Where I think it's one of the hospitals in Cambridge that installed something that had some real post-installation problems.
It's now working. It's epic. But I think what they discovered was what most people discovered with Epic is that the cost of the equipment is about half the cost of the implementation. Software. If you like it, people quote figures, but
what do you think of the fact that digital has now been sort of shoved into NHS England? Is that a good move or a bad move?
I don't know. I mean, I struggle a bit.
I can't figure out what. There's no clarity of purpose as far as I can see. I can't see what they're trying to do.
No. One of the problems I think NHS England suffers from is far too many objectives.
Could we just? I'm sorry to interrupt. Yeah. Nigel, could you just speak up a little more?
Sorry,
they're struggling to hear you. Roy's fine. We've got Roy fine. We're just when
come a bit.
Speak. I think maybe I'm talking to Roy rather than to the.
Catherine.
Sorry.
Thank you. It's okay. Are we still in vision? Yeah.
Yeah. Still good.
Yeah. I mean, one thing that's very striking about the long-term plan is it's really a shopping list, not a plan.
Yeah.
I think one of the
issues. But that was Simon's idea, wasn't it? He didn't want to have anything with strategic markers to it. He wanted it to be fairly free-falling and quite hard, really, to be held accountable with it. I mean, that was the magic of how he wrote that.
The 2000 long-term NHS plan was similar. He was responsible for.
Yeah,
it's
clever, very clever.
It is very clever. I think the question of is it actually the most effective way to get strategic change in a complex system is an interesting one. On your question on digital, I mean, I don't know. I mean, I think, I don't know where else you'd locate it. Right? I don't know what you're.
Well, I would be much more centralist about the whole thing, and I would be much more prescriptive, and I would say we're going to buy this and we're going to plug it in. It's going to work. It will have shortcomings. It won't please everybody, but at least we'll have something that talks to everybody. So I would be much more prescriptive. Mm. And when what was the name of the guy? Gould, wasn't it? Matthew Gould. When Matthew Gould was around, I did a couple of interviews with him. And it was quite interesting. One I did with chief executives, and I said, who would like Matthew to be much more prescriptive in what we buy and use? And the audience was chief executives, and we did a box pop. They all said, yes, be more prescriptive because we can't cope with this. And I did another one with suppliers. And I think Shane's company sponsored that, and I expected to get lynched for asking the question. But actually, they all said, we'd much rather you be more prescriptive because this bidding and all the rest of it, procurement's costing us a bloody fortune. Tell us what you want to buy and we'll make it.
Yeah, so a more standardised approach to the specification of the capabilities of the software and the equipment and how it works and how it fits into the system. Perhaps not, however, we only want one supplier because we're suffering a bit from in primary care, for example, of facing effectively a monopoly, which I don't quite know why the markets.
But you see, that's what is really interesting, man. You and I have lived through this. I mean, we know exactly. I mean, there were no boxes of tricks in primary care until the doctors got completely hacked off. They started a company called EMIS. They produced something they wanted to use. They all bought it, and it all worked. And I mean, that was classic. I think classic. What? I'm not quite sure, but it was classic.
Yes, it's quite different from. I mean, I think specification of standards and how you want to see it working is fine. I just remind you that you're then going to ask the people who managed to waste £15 billion on PPE that doesn't work to procure it.
Yeah.
Yeah. So I don't know
Well, in
what conclusion
fairness,
you might
that
draw
wasn't
from.
NHS England, was it? That did the procurement for PPE. That was done by the commercial Crown Office.
Yeah, and who do you think would do the procurement for something as big as what you're proposing?
Okay.
Yeah.
I'll give up on that argument because you're right. Yeah.
I think the general principle is right. I would agree with you. But
Yeah.
I think we ought to think about how, and I think there's also you need to allow people a degree of local customisation and fitting into systems they've got that work. And we certainly don't want we don't want to get hung up on just a very small number of suppliers.
Well,
but if you're saying about what the standards are, then actually a whole number of suppliers should be able to compete in that market. So,
and I don't really understand why we can't do that. I mean, I don't want to get hung up on technology because there's so much to talk to you about, but I mean, it is a market, isn't it? Really, the NHS when it comes to technology. I mean, look, I mean, Liz, actually playing with Orca. I mean, she's doing a fantastic.
Well, she's in the wild west of it.
Yes, where people are producing apps. Yeah. You can produce an app in the shed, put your bobble hat on, make an app. It's not difficult. Then suddenly, people are using it, and if it's not calibrated properly or regulated properly, people die. So it is absolutely wild west. Is a really good way of describing it. And so, I mean, is it sufficient to say we are in the early days and things will get better? Or do we have to say, we're in the early days and we've got to do better?
Well, we have to do better. I mean, I think one of the issues here is the NHS itself could be much better at helping people in this space understand what the problem is, because it's a bit of a problem in the medtech world as well, which is quite a lot of people with solutions looking for problems rather than the problem is not very well. I don't know whether that.
Or you get people who've got a solution to the problem. There's a gentleman in the audience here. He's got a software device, whatever. I don't know how you quite describe it, but that helps with the people who are in hospital for a long time and the depreciation that they suffer, and flagging, all that kind of stuff. I mean, there is such a plethora of really good stuff around. It's almost like a Pandora's box of stuff. But how do they? The NHS doesn't have one single front door. It's got 1,000 users. It's such a complicated. It's a complicated organisation to sell things to, and I think we the NHS are the poorer for that by not making procurement clearer and easier for people who've got great stuff.
The two other things, though, we also, unlike quite a lot of other health systems, we spend all the money we get. So if you want something new, that has to be got. You have to fund that from making savings somewhere else, or Whereas if your technology is listed in Germany, it goes on the reimbursement list, and if you use it, you bill for it. So there's more scope for bringing in innovation. The second thing, really peculiar characteristic of the NHS is, although it's quite top down and centralised, it's almost like people are taking back freedom. So someone comes along and says, you should use. I remember years ago something I did with using surfactants for preventing for neonates to make sure that they don't get problems with their lungs. And I speaking to one consultant said, "Oh well, we thought about that, but we really need to run our own trial." He said, "Well, there's 150 trials in the Cochrane review. Like, what makes you think you can run a trial?" I think it was at Chase Farm. You'll get even the numbers to be able to get statistical power in your trial. Run around the worst trial because but I haven't. But from what I've heard,
it's a very complicated thing to do.
So it's basically, it almost felt like, well, I'm pretty powerless because of where I sit. But here's an example where I can. So and you hear this continually. It's nice to approve something, and then there'll be a local review to say, well, what do we think about how. So there's a sort of there is a bit of a cultural response to innovation and change. The other issue, I think, is, and this is a big issue with technology in healthcare in a number of countries, is that it isn't producing the productivity and efficiency improvements that people want, because you're bolting technology onto workflows and processes that's still pretty rubbish and uncoordinated.
Yeah.
And I think your question about management earlier was interesting, because I've been reflecting a lot recently that actually, think about the experience of two friends of mine, both have been treated for prostate cancer. Their problem is not poor clinical care. The problem is crap administrative systems that say we're going to phone you on Tuesday, and no one phones, and there's no system to flag that no one's phoned, and when someone does phone you, it's a coordinator. When she's asked questions, she says, "Well, I don't know. You'll have to talk to your coordinator." To which my friend replies, "You are my coordinator," and just sort of like that. You hear these anecdotes continually by anyone. In fact, anyone who's used the health system will tell you, and you hear it in other countries. By the way, it's not unique to us, although I think we may be worse. But technology does not always seem to help with that.
No,
we're not investing in enough thinking about the design of processes.
We look at too much of the high-end stuff. I mean, I watched an NHS England board meeting where Professor, or wherever it is, Dr. Ferris, came scampering in with a pill can, saying that this was going to revolutionise how we looked after people with scoping. And this is like 20-year-old technology that nobody really wants to use because endoscopy is so much more efficient and quicker. And it looks to me like they're all looking at the kind of high end of technology, where really what we want is a booking system that works.
Yeah, so I've had a very interesting sort of Twitter exchange with a whole bunch of GPs, for which it became absolutely clear that there is that as a group, that they were very smart, but they had no agreement on what was the best way of running a system that allowed patients to book to see the GP that they needed to see in an orderly and timely manner that didn't involve an 8 o'clock rush, or there's no consensus. I mean, there may be more than one way of doing it, but you'd have thought it's something as core as a business process. So my friends with their prostate cancer, you'd have thought there will be a system that made sure that people got an important phone call to discuss it at the point that it's been promised.
Maybe we should just ask Ryanair.
So I think we spend far too little time on administrative systems and management and key basic processes. Yeah. I remember being shown around the new walk-in centre in Edgware, close to where I live in North London. And they said, we've had to put up this glass screen because some of the residents of this area, which I was one at that time, are not so nice. And I said, no, I've used this unit. You've had to put up this glass screen because your processes are so terrible that everyone is very fed up with them. Whereas Thomas's, which is it's got the House of the Parliament opposite, so it's really not a good area. Didn't at that point have a screen at all. So I think there's a sort of basic just failure to understand. I mean, it's a long time ago, so I'm sure they're brilliant now. But the basic processes didn't work. The team members were not coordinated. Information was not transmitted. People were inventing workarounds for processes and systems that didn't work. And the question, where is the manager? Where's the middle manager who should be watching that process? The lean technique where you make someone stand in a chalk circle and watch what's going on. No one had watched any of these processes because they would have very quickly realised that the receptionists didn't know how to use their computers. The nurse was doing a useless triage process that had no clinical value. The doctors didn't talk to the nurse or get any information back from the triage process, and their ability to issue drugs was very poor. So just like that's a long time ago, but I bet I'll go back somewhere a unit like that. That will be the experience.
What about?
And it puts great strain on the staff, because the staff spend the whole time doing workarounds for problems that the systems ought to work. And there's nothing that burns you. It's one of the reasons I stopped doing operational management. Is I got fed up with solving that. I thought I solved this problem, and the whole impetus. I think I hadn't been properly trained to think about this. I know what to do now, but then I was thinking I'd solved the problem. I was thinking, oh great, I've solved the problem. But actually, I hadn't really solved the problem. I'd solved that problem. I hadn't actually gone down the root cause to say, well, why is it that ward never gets any linen on a Tuesday or whatever the issue was? So I think we're not paying attention to the right things, and that's why the technology doesn't work when you then put it in, because you put basically you basically made a messy system more technologically rapid.
More messy.
Yeah.
Okay, well, we're in the here and now. Here we are in sunny London with a fantastic view across London. You're leaving us behind for the sunlit uplands. Do you think the NHS is finished?
I think it's in serious trouble, and I think you sort of see the sort of growing noise about, oh, we need charging, we need social insurance, both of which I think are.
Well, if I could just interrupt you, Nigel's done some great think pieces about these, which is on the Nuffield website, and they're really worth having a look. The advert for your you did 3 or 4 pieces, didn't you? Which are really, really good and worth looking at. But sorry to interrupt you.
Yeah. So I think we're in trouble. I think the government seems to have sort of stopped paying attention. The bigger problem, I think you put I thought on your newsletter, a link to Britain is in much more trouble than it thinks.
Yeah.
That's the real issue here. I used to joke that one of the reasons for working in places like Ukraine and Moldova is I was preparing for the UK becoming a middle income country. That is no longer funny. So, people say, oh, we're spending the OECD average as a percentage of GDP. Well, great. But have you seen what's happened to our GDP recently? Yeah. So actually what we spend in absolute terms is a real problem. And most of the high income Anglophone world pays its doctors and nurses more than we do. And we're an international labour market. So, I mean, I think, and there's a global shortage of staff, and we train our staff very well, and they're very marketable. So I think that, and we have, I think, a broken management system for how the NHS works. And I think it's it perhaps.
So where are we going to go then?
I have no answers.
Well, we've got the strike, haven't we? Now we know how that's going to end. It's going to end in tears for the RCN, I think, because the Treasury are not going to give up on this. So the RCN have got to extend their writ in May, I think it is. I would imagine the nurses won't vote to continue striking because actually not all the nurses voted to strike this time. So I think that's going to fizzle out.
I'm not sure about predicting in that space.
We'll have a go.
No. I'm more concerned about the medium and longer term. I mean, I think I think when we start having strikes, it is a worry because one of the
we're going to have more strikes. Junior doctors are going to have another.
Yeah. I mean, so one of the you start losing the. We often have been asking staff to go above and beyond what they're actually paid for. A lot of healthcare does. We need to sort out these systems don't work well. Does require quite a lot of people going beyond discretion, giving you more discretionary effort than you probably pay for. A lot of it relies on goodwill. The effective functioning of hospitals requires. And you remember the Virginia Mason thing. The key bit about Virginia Mason, I thought, was less than lean, was more about the effort they put into making sure that the relationship that the hospital managers had with the clinical staff was an appropriate, well-balanced one, which gave both sides of that equation what they want. And I think, I see in a number of health systems in the UK, it's similar, a real risk that you lose that. And one of the mysteries that people have been worrying about and the IFS wrote about, and I know NHS England's board have talked about, is how can we got all these extra staff? And you have a lot of extra staff, right? I mean, it's not like number of staff in the NHS is bigger than it ever has been, but productivity hasn't gone up. We don't know who they are or what they're all doing, but they're probably backfilling lost discretionary effort. And also, well, I think there's a lot to be said for using skill mix. Generally, fewer better people is a good rule. Yeah.
Do you detect a political will to sort this out, or do you think they're just stepping back and seeing what happens?
I guess there's no particular. Frankly, there's nothing. Elections in 18 months. The number of things they can actually do is not that great. It will really make a big difference. They don't really seem very interested in the NHS. I think they reckon they'll never win on health anyway. And there is a bit of no good deed goes unpunished in this space. So I think they're not. To be fair to them, they haven't got very many political options open to them, and I don't think they're thinking much beyond the elections. Why would they? I guess, except you might think your job is the stewardship of the country and how it works, and you might think beyond your narrow political.
Well, we're likely to see, if we think about it, we're likely to see the economy in a better shape, bit better shape anyway by the election. They're going to throw some money around of some sort. They usually do, tax breaks or what have you. The nurses or the NHS will probably get some more money, and they'll take their chances at the election. Because, but you know, we think about the Labour Party going to could form the next administration. Actually, they need a bigger swing than Tony Blair had in 1999, 1997. So I don't think it's a slam dunk.
No, but even so, whoever wins, I mean, I was just about to say that the fact that no one has fixed social care, or even seen, so Boris Johnson's version of fixing social care was about inheritance, which is just show you how little he actually cares or knew about what the issues
or understood.
were. Yeah, but the social care market, as you know, you've written about this, is in serious trouble. They're outcompeted by everyone from Amazon to Lidl. We have this big problem that I know the government is very concerned about of people who have exited the labour market. So it's not like we've got a big pool of unemployed people who we can pull into these. So not fixing social care will probably still mean that the ambulances will be queuing down the road at many hospitals because we can't get the people out. That's very visible. So I think that, and then in general practice, common again with other countries, we've got high levels of burnout, the workloads are high, but dissatisfaction there will continue to be significant. People use general practice a lot, they will notice that, and that will so I think there's big problems which don't have immediate solutions. Certainly changing the partnership model is not going to solve anything. So I think we've got a shortage of ideas, and to be fair to them, there aren't that many very easy things to do.
No. Right, I've got an eye on the time. We've got about another 15 minutes. If you have a question that you want to give us, you can just type it in the comment box, and John will pass us those questions, and we'll leave some time at the end to see if anybody's got any questions they want to answer. Looking back, I did a really interesting health chat with the editor of the Health Service Journal a couple of probably last year now, wasn't it? And we kind of thought about secretaries of state and ranked them. When you look back over the secretaries of state, and I think I'm on my 23rd, I think now. When you look at I'll go first, right? Give you time to collect your thoughts. I thought Patricia Hewitt was a very good Secretary of State for Health. She came in after Frank Dobson, who allowed the NHS to overspend horribly, and then she came in. Then she came in and said, John Reeves, yes. Then she, that's right. Dobson had done the damage by letting people overspend. John Reed didn't seem to be interested. Then Pat Hewitt came in and said, the NHS has got to stop and it must balance its books at the end of every year. And everybody had a heart attack because there was no way of doing it. But I enjoyed her, and I'm pleased that she's back. Who do you look back on fondly?
You've left off Alan Milburn from that chronology.
Yeah,
Dobson, Milburn, Reed, Hewitt.
And then Hewitt, right. Well, Milburn, of course, was the great privatiser, although the Labour Party will never admit it. He set up got the internal market roaring. But who do you look back on with fondness? Or perhaps fondness isn't the right word.
Definitely not the right word.
Yeah, but with lack of less astonishment.
All of them are have. So Patricia Hewitt. I was less impressed with her.
Really?
Yeah. I mean, I think, to be honest, she had a hard brief. There was an abortive white paper, which didn't really get it.
And she got her into trouble with the Septim as well, didn't she? Breast.
So she decided that we didn't need to wait for evidence on the Septim, which was brave. Milburn was a difficult character, but did have some vision and energy.
Yeah.
And that made up a lot for some of the issues with him. I've quite a soft spot about Alan Milburn. It was quite effective. It was actually quite effective. Many of them, sometimes wrong but never uncertain. Sometimes say about a particular specialty in surgery. But yes, he had a slightly sort of bullish, overly bullish approach. Quite highly centralist, very impatient, which is sometimes not such a bad thing. Did really help get the money. was a great advocate for the NHS.
Well-
Invested a lot in improvement.
Well, they got waiting down to almost. Burnham came after him.
No.
Was it Andy Burnham?
No, Burnham came after Shearer.
Yes, that's what I meant. By the time Burnham was Secretary of State for Health, waiting time had come down to almost nothing.
Yeah.
We had a full workforce.
So Milburn put in the money. He got the money. He got Blair to give him the money, and that's a lot to do with him. He has quite a bit to do that. He listened to council that said you need to have other methods to make this work. We had the modernisation agency, which were really successful. I thought there was cancer improvement plan. There was improved GP access. They actually invested in workforce as well. So I think Milburn, you can't take all of the credit for that. I think
Was that the beginning of a golden era?
Well, actually, I think there's an argument. So we actually had too much money at that particular point. When you look at some of it was spent, I would say, and we probably overexpanded the number of specialists and didn't invest in general practice enough. But the sort of energy and force and willingness to use a range of different policy levers than just shouting at people, which has been the technique. So you did. I mean, they brought in paying by results, which mixed but interesting. There's new GP contract, not so great. That was agreed. I think Reed was in. Andy Burnham was a bit caretaking, but there was an attempt to try and give it some energy back. But there was a bit of me feeling that there was quite a bit of pushback from bits of NHS management to try and recontrol the agenda on improvement and take it back. Take back. The SHA's undermined the modernisation agency and sort of torpedoed it a bit, and a sort of dead hand of top-down management was quite quickly reimposed. But Reed came in and immediately started thinking about how to circumvent the trust's freedoms.
Okay, we got some questions. I just want to ask. Okay, well, let's do the questions now. Yeah.
So we've got Wamba would like to ask Nigel, what's the best advice you can give us to sustain a career in health and social care as long as yours?
Well, I've, of course, not worked for the NHS for most of it.
Next question.
Thank you, Wamba. There you go. That was interesting. And then we got one from. Do you want to expand on that?
The people I've seen, there is a sort of. There seems to be two approaches. One is, which I'm not so keen on, is keep moving.
It's harder to hit a moving target.
But the other, I think, there are some roles where being deeply embedded in the community of the organisation you work with and the place you're in, it gives sort of emotional and other sustenance.
Well, look at Jim Mackey.
Jim Mackey is a very good example. Andrew
Morrison.
So I think organisations, my organisation needs a new CEO because it's that type of organisation. But quite a lot of hospitals, particularly, and I think also probably community service and mental health providers, there's something about leadership continuity that's very powerful and important and helpful. It's a good leader. Otherwise,
perfect. We've got another question here. Then we're going to go into the room. So, what does Nigel? This is from Sue. She says, "What does Nigel think about Dr. David Haslam's suggestion that we need to go back to basics to clarify what the NHS's job is? Productivity is eroded by mission creep, covering for other areas that are underfunded or have been cut."
Yes, I think he has a good point. I mean, the only slight problem is that it's always very easy to add things onto the list that you do, but the minute you try and take anything off, so you often hear people say, "Oh, we need an honest conversation with the public," which always makes me slightly queasy. What do you think we were proposing? A dishonest one. But actually, experiences in other countries with trying to set what's called the basic package. So this is the benefits package as well. Very politically difficult to take anything off it.
That's nice.
You can control its growth.
Part of NICE's job is to disinvest in things that don't work, and I think that they tried it with grommets for the years, and that was it.
Yeah, and actually, a huge round. Almost quite a lot of this stuff does work for some people, so you can't. So then you get into some social values thing, and I think so I haven't read David's reports. It's on my list of things I really ought to get around to reading, but you start to pick up things which sort of life cycle or additional. And then so good luck with an argument on IVF, for example.
Yeah. Done that on the telly and it never works. Right, in the room. Yes, sir.
Thank you very much.
Just tell us who you are.
My name is Benedict. I lead a company called Sanome. We build early warning systems for health deteriorations in clinical and care settings. Health deteriorations. Diagnostics are very often the unsung hero of the healthcare system. Yet from an investment point of view, they haven't really generated a return. No one really talks about them that much. How do you see how diagnostics play a role today and going forward in the future?
So diagnostics are a very interesting example of where your standard economics textbook and business textbooks get you into trouble, because quite a lot of the diagnostics allow you to do more for the same people rather than treat more people. Yeah. So we can do, which is great, and it probably means if we were better at measuring what the quality of our output was, we'd be able to say, oh look, actually we're getting better value. But we haven't really got good definitions of value. We still just count numbers.
Yeah. Well, we've just published one exactly that.
Yeah.
Topic.
Oh, good. Well, so this wasn't the setup. I didn't know that. But, so I think that's the diagnostics I was also alluding to earlier. That the diagnostics involves large capital investment, runs foul then of our short-termism and lack of willingness to invest in capital. So we've got a problem. So
we run into problems with workforce.
We're bad at that. Yeah, we certainly do. We're bad at evaluating what the outcome actually is. The other problem I think I would say though is that there's a bit of a naivety in some bits of the industry to think that the full cost saving, the classic, if you buy my technology, I can save you £8 billion. Well, you can't really, because most of that 8 billion is fixed cost. You can probably say, you can save me 2 and 8pence.
Well, if we put all the people together that tell us we could save money, we could actually run the NHS for nothing.
They'd be paying us.
Why don't we do that? Okay, who's next? Yes, Shane.
Stephen Dorrell and Alan Milburn were on a stage about 5 years ago interviewing each other, and the question was, if you could give the NHS anything, what would you give them? And they both said, well, actually, it'd be 10 years. And I think shortly after that, Sir Simon Stevens came out with his 5-year forward. And if I look at 2022, the most leadership country that we had, and all the things that weren't decided upon, we can't afford to do that. And I think the responsibility of social care to now come under the NHS. I was listening to you say about digital and transformation of things. And as a digital supplier, for many years, I was told, make sure your systems replicate the 30 or 40-year-old systems we've got today. Otherwise, there's no business for you. And I think what we're talking about here is if we're going to change processes, care flows, and that's what I hear the mood music is, care flows across sizes like an ICS, which I'm a big fan of, 1 to 5 million population. But I think there's 2 things that we're missing. One is the freedom to think. We talk about giving people headroom, but the freedom and time to actually think, and then selling the vision of what that change is going to look like. We talk about change and transformation, but that's not the important thing. It's what it's going to look like the other side, and that's why I think people buy into change.
Yeah, I'm going to interrupt you because we've got 2 minutes left, and I think Shane makes a very important point, and a lovely answer. What we give it time, and that's probably, there's not very much more to say about that. It's true.
I'd agree with that.
It's a very good answer. Look, we've got a couple of minutes left. Tell us what you're going to do next. You're going to manage a test code, eh?
No, I'm hoping. I hope I will still do interesting things with ICSs and things in the NHS.
I hope you do.
And I'm talking to a couple of those people who operate in the NHS to make sure I've got an opportunity for that. I'm going to help a team at WHO Europe and Copenhagen on thinking about hospitals, and with the World Bank on that. Working with a team based in Almaty in Kazakhstan, which is a Europe-wide collaboration on primary care improvement. Because I'm a great believer that if we don't get primary care right, everything's going to be hopeless. So that's
we wish you luck with that. I mean, from my personal perspective, I've always thought you've had a really interesting career. I've much admired what you've written and said, and I think it's going. Seriously, we're losing a serious and interesting thinker about the health service, and I'm very sorry to see you go.
A job advertisement for my post is available if people are interested.
Well, if I could fit it in with the day centre bingo, I might have a go myself. But no, seriously, for what you've done and made us think and provoked us, we're enormously grateful, and we're very grateful to you for giving us your time this lunch. We wish you well with your career, and I hope the second half of your career is as successful as the first half. And that brings us to the end. I hope you've enjoyed spending your lunch hour with us. We've got another health chat coming up, I think, in 30 days' time. Is it not quite 30 days?
Less than that.
Yeah. Less than that. Just have a look at my e-letter or look at the IHSCM website. It's a really interesting. I've got 3 leading chief executives who we're going to have a conversation about what it's been like to manage these big organizations in these very difficult times. So I think that's going to be a really interesting insight into the challenges of management. So I've enjoyed enormously being back, not being an abattoir, and to be back in the flesh, so to speak. Thank you so much to our sponsors, all of us, and thank you so much, Mills and Reeve, for a spectacular view. You can't see what I can see, but I look out there and I've got a spectacular view of London. So we're going to go and enjoy that. So we're just up now to the stroke of 1 o'clock. Thank you very much for joining us, and I look forward to seeing you again next time. Thank you very much. Bye for now.